Hello, everyone. I'm Marcia Mott. Welcome to the UF Health Wellness University webinar. Thank you so much for joining us today as we discuss migraine headaches. I'd like to introduce to you our first speaker, Dr. Yulia Orlova. Dr. Orlova is an assistant professor in neurology at the University of Florida in Gainesville. She specializes in the diagnosis, management, and treatment of headache disorders, including migraine, cluster headache, tension type headaches, and other headache disorders. Dr. Orlova received her medical degree from the Siberian State Medical University in Russia and completed her neurological residency at Rutgers Robert Wood Johnson Medical School in New Jersey. She was fellowship trained in headache medicine at Harvard Medical School. She participates in clinical research in migraine. Dr. Orlova's clinical interests include migraine, chronic headache, migraine cluster headaches, secondary headache disorders as well. If you have any questions for our speaker today, you can submit written questions at any time using the Q&A feature at the bottom of your screen. At the end of the presentation, I'll read your question anonymously. I will not read your name out loud, and we're only accepting written questions today. We're going to try to get through as many questions as we have time for. Thank you so much. Dr. Orlova, I'm going to turn over to you now. Thank you. All right.
Hello.
That was great.
Hello, everyone, and thank you very much for this opportunity to talk about the very common and yet poorly understood medical condition, migraine. The topic is very close to my heart, as this is, I devoted my career to this. I wanted to start with the fact that the migraine is known to humans for thousands of years, and yet we're just beginning to understand this condition. As the topic states, we're going to cover a few myths, misconceptions, and mysteries of the migraine. I would like to start with one, the first misconception or myth that is a statement that migraine is just a headache. The language that we use describing headache disorder is very important because words that we use may have different meaning. First of all, if we talk about headache, it can be a descriptive term for pain in any location of the head, but it's also used by public and media to describe a thing or a person who is causing trouble or worry. That's why the Coalition of Headache and Migraine Patients recommends using more specific term, headache disorder, that might describe a number of different medical conditions. There are more than 100 known headache disorders, which can be divided broadly in two categories. First is a primary headache disorders that includes migraine, tension type headaches, cluster headache, and some other disorders that affect less people. And those are disorders in their own right. They're treated with specific acute preventive medications and non-pharmacological treatments that we're going to talk today about. And second group is a secondary headache disorders, when headache is a symptom of other condition, and the main treatment, of course, would be going after the cause. Finally, migraine is even more specific medical term, which describe a chronic medical condition with recurrent attacks of severe headache and other associated symptoms. It's also most common primary headache disorders that lead people to the doctor, including emergency room. And migraine attack, in medical terms, is a severe headache associated with other features characteristic for migraine disorder. I also wanted to bring to your attention that Coalition of Headache and Migraine Patients that I mentioned earlier put together a headache and migraine disease language and image guide, which explains why disease language matter. Language that is used can affect public perception and institutional response to this disorder, and those who have it. In this document, the coalition recommend to use the term person with a migraine, not the sufferer, not the victim or migraine personality, describing an individual who has disease but not defined by it. It is believed that word migraine came from French, which itself derived from Latin hemicrania, meaning that pain on one half of the cranium of the head. Oxford English Dictionary offers following definition. It's a severe headache which characteristically affects only one side of the head and is typically preceded or accompanied by visual or other neurological disturbances and is associated with nausea and vomiting. It's also described as syndrome characterized by recurrence of such headaches. So it's both a symptom of a disorder and a disease. Can make it quite confusing sometimes. One of the large textbooks on headache medicine defined migraine as a very common neurological disorder. And it is characterized by, again, recurrent attacks of severe headache, autonomic nervous system disturbance, and in some patients by aura. I would like to bring to your attention the fact that migraine is defined as medical, more specifically neurological condition with various signs, in addition to recurrent severe headache. This is an important distinction as it goes beyond just description of symptoms, and it's also acknowledged that there are different types of migraine, with or without aura, among others. The visual representation of migraine is also affects the public perception of this condition. In 2018, one of the fashion magazines published an article featuring the glamour posing for Instagram, calling this headache pose, depicting celebrities touching their temples, allegedly it's firming their skin and making the picture more appealing. This was followed by other newspapers, again talking about migraine pose as the most flattering and attractive. But people with a migraine felt that this visual representation of migraine is insensitive, trivializing this condition and lacking in cultural literacy. Many people posted their real migraine pose and shared that they have been suffering for years, missing work days, their interactions with the family, leisure activities. There's nothing glamorous about it. Now I want to take a look at these pictures that have more accurate representation of headache disorders. I want to point out that headache diseases occur in all races and ethnicities, so it's not the only disease of white women as commonly depicted. Headache diseases are disproportionately prevalent in members and veterans of the military. Next picture of a mature woman that has migraine. Migraine often decreases with age, but not always. Women are very commonly told that migraine will resolve after the menopause or even after hysterectomy, but this is not always the case. Children also experience headache diseases, and headache diseases interfere with their education. Actually, in young children, migraine is more common in boys than in girls, but in teenager, migraine is more common among girls. Finally, headache disease impact men as well. So this is a medical condition and is common among all ages, ethnicities, genders, and occupation. So how common is migraine? It is actually one of the top disabling condition in the world. Did you know that migraine is more common than asthma and diabetes combined? This graph shows data from Centers for Disease Control and Prevention. For example, in 2002, disease prevalence or the total number of patients that year was 5% for asthma and 6% for diabetes. So when you combine, we get 11, while migraine affected 12% of population, which means that every 7th person has migraine. It's a lot of people with migraine out there. And this brings us to one of the migraine mysteries. Why there are so many people that are affected? From biological point of view, we do not know if migraine gave any evolutionary advantage to the humans, or it may be results of poor adaptation to rapidly changing environment. There's multiple theories about this, there are a lot of debates, but for example, migraine might act as defense mechanism against excessive noise, light, or stress. But with a change of the culture and living condition, such as invention of light bulbs and fluorescent light, living in the tight spaces, with the information overloads that we all have, they all can cause an increase in migraine frequency because our brain may not adapt fast enough to changes in our environment. Again, as I mentioned, those are just the theories, and we don't have a good answer to the question, is the migraine a defense mechanism, or it is a defect of the brain function? We do not have definitive answer to this question. Nevertheless, lifestyle modifications targeting stress, management, reasonable management of certain triggers are all employed in treatment of this condition, even though there's still no experimental proof that this approach is effective. Other factors contributing to this include poor recognition of this condition. Unfortunately, migraine is under-recognized and under-treated. Doctors do not have sufficient education in headache disorders, and some of the studies in academic journals published that 1 or 2 hours of headache education in medical school, that's all doctors graduating in medical school have. And there's also stigmatization of this migraine in a society as trivial disorders that affect weak people who do not know how to cope. In one of the examples we just looked at with a so-called migraine pose. Migraine does not decrease longevity, and it needs to be managed during the very long period of time, and sometimes during the entire life of the individual. So as a human population grows, so does the number of people with migraine. Finally, migraine is treatable disorder, but unfortunate treatment is not always successful, and there's no cure. Available therapies are effective in about 30 to 50% of the patient. And even if it's effective, many patients abandon the therapy because of the side effects. Where does a migraine come from? This is another mystery that links closely to our understanding of this condition and eventually the management and the treatment. Headache has troubled humankind since the earliest times of our civilization. And understanding of the migraine has changed dramatically over the centuries. The earliest mentioning of a headache can be found in Mesopotamia, modern day Iraq, dating from 4000 BC. And it indicated beliefs that headache was caused by evil spirits or devils. Aretios of Cappadocia first distinguished migraine from general headache. He noted that it is periodic, affecting one side of the head, and has associated symptoms such as nausea. Another famous ancient doctor, Galen, defined different types of headache as cephalalgia, cephalea, and hemicrania as separate headache types. Notably, this terminology dominated for almost 2000 years, and we still use those terms. But more recently, the observation of several physicians and scientists shaped the modern understanding of migraine as neurobiological disease. For example, in 19th century, Dr. Hubert Airy depicted a superb imaging of his own vision aura, which is transient visual disturbance affecting about 30% of the people with a migraine. I'm going to show you his picture a little bit later. In 20th century, it was Dr. Harold Wolff who explained pain due to dilation of the vessels of the brain lining, the concept that called vascular theory of the migraine. And this theory dominated in science of migraine for most of the 20th century. It proposed that migraine develop in two stages. Vascular spasm causes neurological symptoms at the beginning of attack, which followed by compensatory stretching of the arteries, which cause the actual pain. However, later studies showed that vasodilation or widening of the vessels does not correlate and is not necessary to generate the pain. It also became clear that medications that now used to abort the migraine attacks actually do not work by changing diameter of the vessels, as we thought initially. In mid-20th century, Dr. Carl Lashley, again observing his own aura, suggested that it comes from a wave of intense excitation that is traveling across the occipital cortex, or neuronal cells that are located at the back of our brain. And this is a part that's responsible for our vision. So this wave is followed by complete inhibition or slowing of activity of the cells with gradual recovery. And this is a phenomenon that now is known as a cortical spreading depression. And this concept also served as a basis of neuronal theory of migraine. Around the same time, Dr. Aristides Liao discovered cortical spreading depression in the brain of the rabbit, solidifying our understanding of the migraine as a brain disorder, and basically confirmed in experiments that it does come from this phenomenon does exist in a brain, the phenomenon of cortical spreading depression. According to modern theory, migraine is a disorder of the brain with genetic basis when multiple brain regions can generate migraine symptoms with the release of different substances that are now used as targets for treatment. If you look at this diagram from Dr. Charles, published in 2018, he proposed that there are multiple factors such as genetic, environment, hormonal, certain drugs can lead to activation of a different part of the brain. This, in turn, can lead to activation of different parts of the brain and activates the brainstem located at the back of the head, leading to a release of different substances, causing the actual head pain and other associated symptoms. And perhaps that because there's so many different players with involvement of different parts of the brain and other factors, symptoms of migraine vary and even in the same individual. I think that the triggers of migraine deserve more detailed talk. Triggers of migraine have been recognized for centuries. One of the migraine mysteries is why there's so many triggers and how exactly they can trigger the migraine attack. The most common triggers reported by people who have a migraine are psychological stress, irregular sleep hours, hormones, weather changes, caffeine and alcohol, light, dehydration, smell, certain foods, and overuse of medication. While some triggers can be easily avoided, many others are not. And in fact, role of triggers is likely overrated. First of all, triggers are quite specific for an individual, and what is common trigger for you may not be a trigger for someone else. But identifying your own triggers may help to find a way to cope with them. For example, if you are sensitive to dehydration, make sure that you drink plenty of fluid before you go for a walk or exercise. Remember that you're well hydrated when your urine is nearly colorless, and it's not about the number of glasses of water that you drink. It's about how much of water you need at a given time and a given day. Also, some of the factors that are commonly perceived as a trigger may actually be symptoms of abnormal brain activity at the earliest stages of a migraine before the actual head pain even started, so-called premonitory symptoms. And this is a very interesting concept which changed the way how we see triggers and how we think about management of migraine as well. This brings us to different phases of a migraine attack. Migraine attack has several phases, and a head pain is one of them, but not the only. One more reason why migraine is more than just a headache. About 75% of the people with migraine can experience symptoms, what we call premonitory or prodrome, hours to days before head pain. They may include fatigue, sensitivity to light, certain food cravings, including chocolate and salty food. So there's one of the theories saying that the reason why chocolate is commonly caused as a trigger of the migraine may not be the chocolate itself. It might be the craving during the premonitory phase, which reflects activation of some of the parts of the brain. And it's telling us that migraine is on the way. And what's triggered in some of the food triggers may not be the actual trigger, but the symptoms at the earliest stages. About 30% of people with migraine experience aura. And this is a transient neurological symptoms, most commonly visual, and less frequently a sensation of pins and needles, numbness, weakness, usually on one side. Typical aura lasts from 5 minutes to 1 hour and usually starts before headache, but not always. There is also some individual will experience auras without headache. In some individuals may have some attacks with aura and other without. And we still don't know if migraine with aura is biologically different from migraine without aura. There's a multiple theory which go beyond this topic, but I just want to bring to your attention how variable of the symptoms, even in the same individual. Next phase is actually head pain, or the headache pain phase. It typically lasts from 4 hours to 3 days, and it may follow by post-trauma. Some people call it migraine hangovers that can last hours to days. So you can see that if the actual pain may last 4 to 72 hours, and it's a pretty long duration of the pain, but there may be some other symptoms before the attack and after that still affect the individual, and this individual attack may last up to several days. Here's the pictures that I mentioned before. On the right here, you see drawings of Dr. Hubert Aries. That's his own vision aura, and you can see that he documented that it starts as a little dot, then it grows, it spreads, and there's a beautiful, colorful rainbow on the side. This picture looked to him as a map of an old castle, and that's why there's one of the terms that we use for this particular pattern of vision aura as a tacopsia. And on the left, you see the pictures. If you follow this YouTube link, you can see development over the time. And again, you see this beautiful rainbow color on the side of the periphery of the vision, and there's also a blurry spot. And the individual who has these symptoms do not have headache yet, but that individual knows that that's how it starts. And once this beautiful scintillating scotoma is gone, that's when usually severe head hits. Let's move on to the management of migraine. There are several building blocks, and I'd like to talk about the general principles first. Preventive treatment is considered when a person has from 4 to 10 headache days a month. So if you have very infrequent attacks a few times a year, you don't necessarily have to take daily medications, and the treatment of acute attacks may be sufficient. But if a person have a frequent migraine attacks, then would be the time to consider preventive medication. And the goal for preventive treatment is to reduce headache frequency and intensity of the pain. It can also help to improve an effect from acute treatment of individual attacks. Second block is acute treatment of individual attacks when it starts. And I recommend my patient to treat migraine early at the very onset of attack, but not too often, because if the person uses acute medications that are short lasting too often, it can cause complication called medication overuse headache, which brings us to the third building block, prevention of medication overuse headache. And the way how we see a medication overuse headache now is it is a complication of the migraine. And for some reason, people who might be taking Tylenol or ibuprofen for joint disease, but if they don't have migraine, they will not going to have rebound headaches, or old term used for medication overuse. Something about the brain of the person with a migraine makes them predisposed to this condition. And a combination of medication, which is over-the-counter Excedrin, or old medications that used for migraine as Fioricet, opioids such as Percocet or Norco have higher risk of this condition, while some of the non-steroidal medications may have less risk. But still, this is something that you should be aware of. And if you find yourself that you reach out for acute medication more and more often, it's time to think about preventive therapy and consider that maybe no medications that's supposed to help you no longer helping you and actually maybe triggering rebound headaches. But this is, of course, easier said than done, just to prevent. But even being aware of this condition might help. So that's why I thought I'll bring it up during this talk. And this all brings us to another migraine mystery. What is the management? How do we treat this condition? Right? I wanted to look back at this migraine funnel of migraine mechanisms, or migraine cascade. And here's where I would put different therapeutic approaches. So you may consider that avoidance of specific for you triggers, we probably will put here the factors contributing to migraine. And sorry, this was actually preventive medication. So I just spotted this should be here. Preventive medication work through the different mechanisms. There's a number of different preventive medication with different mechanisms of action, and they all may affect different parts of the brain and affect different mechanisms of a migraine disorder. And the acute treatment of individual attacks, I should have placed right here with the release of individual substances. There's the CGRPs listed here, PACAP, and I would probably include here serotonin, which is a target for a number of acute medications. So sorry for this misplacement. But actually, there's a category of the treatments that now merge together acute and preventive treatment. And those are the novel medications, both injectables and oral medications that are gonna give you a few of those I'm gonna mention a few of those in a minute. So different approaches work through the different mechanism and the different levels. Here is a list of current preventive therapies for migraines that we use. Therapeutic monoclonal antibodies against CGRP. So CGRP is a protein that we all have, but it is released during migraine attack, and blocking this protein or its receptor shown to be effective as prevention of the migraine. Botulinum toxin is another injectable. It was studied in clinical trials for chronic migraine. Chronic migraine is migraine with a frequency of 15 days or more a month, meaning that the person has more days with headaches than not, and at least half of those are migraine. The rest of the medications that I list here are well-established oral medications, beta blockers, one of the blood pressure medicines, such as propranolol, metoprolol, some of the antidepressants. Not all antidepressants work the same way, and not all of them shown to be effective for migraine prevention. And tricyclic antidepressants such as amitriptyline or nortriptyline, and duloxetine or venlafaxine are included in this category. Non-selective calcium channel antagonists such as verapamil, a number of anti-epileptic drugs, but not all, topiramate and depakote were shown to be particularly effective in migraine prevention. Some other blood pressure medicine, angiotensin converting enzyme inhibitors and receptors antagonists such as losartan, cambesartan, lisinopril, and finally a number of medicinal herbs such as feverfew, for example, vitamins, particularly vitamin B2 and minerals, particularly magnesium, were studied and had a clinical trial with reassuring results. So all of this class of drugs can be employed in prevention of a migraine. And there is a number of medications that and non-medical approaches used to treat individual migraine attacks. And when we talk about migraine-specific therapy, targeting specific substances that we know contribute to head pain, it's non-selective serotonin and dopamine agonists such as ergotamine, ergot's derivatives, selective serotonin receptor agonists that work through 1B, 1D, and 1F receptors. And the newest class of drug of serotonin receptor agonist would be lasmiditan, which only works through serotonin receptor 1F, but not through 1B and 1D. And this is where is another evidence from the fact that it's not effect on the vessel that is responsible for headache relief. It's other mechanisms, the blocking of release of painful substances, that the mechanism of action of these medications, because 1F receptors is not located on the vessels, and it's yet is effective in migraine attacks. Selective CGRP receptor antagonist, this class of medication called GPANs, and the example is rimegepant and ubrogepant or Ubrelvy and Nurtec. Those are the newest medications. Non-specific therapy, simple analgesic and such as Tylenol and non-steroidal anti-inflammatory medications. Opioids, which I do not see as a first line because they're not the greatest medication, but sometimes we have to use them. And they're either last resort or when the person has contraindications to other medications. Butalbital containing products, we already talked about furosemide and potential risk of medication overuse, headache. And neuroleptics or dopamine antagonist medication that's very helpful to treat nausea and vomiting associated with migraine. And finally, the neuromodulation devices. So not every migraine attack, not every person with migraine need pills or injections, and sometimes non-pharmacological approaches designed specifically for migraine treatment might be helpful. Neuromodulation devices such as cephaly or transcutaneous nerve stimulator. It's a little patch that people would apply on the forehead and develop electric stimulation during the attack might be helpful. Nerivio is a remote electric neuromodulation. It's a little patch that people would apply to the shoulder, and they can operate it using their cell phone and increase or decrease the intensity of electric stimulation. Non-invasive vagal nerve stimulator using a gamma core device, and a single pulse transcranial magnetic stimulator device in neuro. All of these new approaches also developed in past maybe 10 years or so. Unfortunately, most of them are very expensive, and I see this probably as a main limitation for their use, but that's a completely different topic. And that's all that I wanted to share with you, and thank you.
All right, thank you so much for that. I'm going to ask you to turn your screen share off, and we'll take some of these questions that we have now. A question that was submitted to me in advance says, I suffered from migraines for many years. After averaging 1 or 2 a week, several months ago, I started experiencing pain and stiffness in my neck and skull every day. When I have a migraine, the overall pain is much more difficult to deal with. I recently discovered Occipital Neuralgia, or ON, and it's often mistaken for migraine. Can you talk about ON, Occipital Neuralgia?
So occipital neuralgia is a condition very commonly associated with other headache disorders. And it's maybe as commonly underdiagnosed and overdiagnosed, because the neck pain and occipital pain is very, very common in the migraine. And in fact, because it's the same area of innervation, then we use occipital nerve blocks as a treatment for individual migraine attacks. And the fact that there's a tenderness on the back of the skull, and it can also spread to the neck and can spread behind the ear, can spread all the way up to the eye. So there is a common mechanism for this pain. And, we consider the head and neck, well, anatomically they are related. And in fact, some of centers that triggering the headache are located on the top of the neck. So there is an anatomical connection. But with occipital neuralgia, there are certain diagnostic criteria that we use, and there's a shooting pain, usually brief, and I commonly see it as a complication or another condition that patients with a chronic migraine have. So not everything that's located in the occiput is occipital neuralgia per se, but from point of view of a treatment, using medications that calm down the nerve, anticonvulsants, the medications that help to reduce the painful stimuli in occipital areas, such as nerve blocks, can all be helpful. There is a recent emergent therapy for some of the headache disorders, that's occipital nerve decompression, which is still in the development. It's not every center has a kind of experience with the treatment, surgical treatment of this condition. But again, what I see in my clinic and in my patients, it's very, very common conditions that is overlay and come together with other headache disorder. It's not a single disease by itself, some kind of merging at some point.
Okay, it seems like migraines are like untangling the ball of yarn sometimes and figuring out what all contributes.
Yeah, one of the way to look at the migraine as one of why migraine is so important in headache medicine, in the science of headache medicine, that we can see migraine as abnormal pain processing. So the person with a migraine responds to other conditions in a different way than the person who does not have a migraine. And that's why one person with a migraine can have other headache disorder much more common than the person who does not have a migraine.
Okay, thank you for that answer. Is the location of the headache diagnostic? Like, does a headache in your temples mean one thing while a headache in your forehead means something else?
So that's a very interesting question, though. In primary headache disorders, when it is disease of the brain in its own right, and it's not caused by tumor or stroke, meaning that there's nothing pressing on the nerves, the vessels or brain lining, location is not really give us much to diagnosis. It is a change in the side and variability of symptoms as a hallmark of a migraine. So in migraine, one attack may be on one side, another attack may be on another side, or frontally located on the back. And that is one of a characteristic of the migraine. So it does help to establish diagnosis. So what it means for me as a physician, that if there's variable locations of the pain, then we most likely we're dealing with a primary headache disorder. It's when the headache is always only on one side, only in one location, that I have to think twice if there is another condition. So variability of symptoms generally is reassuring that there is no structural life-threatening condition. If one individual has attacks one day in the temples, another in the forehead or in the back, no, it does not change our diagnosis most of the time.
Okay, thank you for that. Could you describe what an ocular migraine is? You talked about it a little bit in your presentation, but maybe we had several questions that came in about that. So maybe go a little bit more in depth about that.
Yeah. So the ocular migraine is a term that in headache medicine we do not use. And it can mean several things. It's one of the older terms. And the classification of headache disorders that we use currently, which is a third version, can you imagine that the thousands of years that humankind suffers from migraine, only recently this condition were kind of put together and classified. So what term ocular migraine can mean most commonly means that person has a migraine with aura, with vision aura specifically. All those pictures that I show you, this blurry spot with a rainbow on the side, those are the largest category of the ocular migraine. There is also less frequent and considered to be a rare disorder of the retina, the lining of a nerve ending inside of the eye. But it may look exactly the same. The difference is that abnormal electrical activity starts not in the occiput, not in the back of the brain, which is responsible for our vision, but in the retina. So those are the two categories that commonly described as the ocular migraine. So it's not the pain in the eye, it's very common. It's a vision symptoms, that phenomenon of the migraine, as a sign of abnormal electrical activity traveling to the different parts of the brain or retina, if this is a retinal variant.
Okay, so a related question to that is, can you recommend something to deal with or what to do when the vision changes like that occur? When you're having the aura and the cloudiness of your vision?
Because we consider the migraine aura as a part of the migraine attack, the general approach is the same. So if a person has frequent events, then would be probably time to talk to a doctor about preventive therapies and treating individual attacks early during the aura phase. I do advise my patients, and when they have this vision aura and if they're driving, you need to pull over and wait, because this is some things that can affect your vision, and that can be very, very disturbing, especially if a person experiences it the first time. And the medications that affect brain activity, all magnesium can be used and employed in this condition, or other preventive medications that I mentioned. So basically, because it's a part of the migraine, we would treat it as a migraine. And sometimes people able to abort their attack when they treat it during migraine aura period before headache started, but not always work out, unfortunately. So I would suggest think about preventive therapies.
Okay, thank you. We have a question. Excedrin migraine and Excedrin headache are on back order virtually every place. These are sometimes helpful and affordable. What do you recommend until Excedrin supply chain is fixed? I guess maybe there's a shortage of.
Yeah, so I cannot comment on about the supply and everything. What I'll say about Excedrin is that it is a combination of medication, and the active ingredients is either Tylenol or aspirin and caffeine. And those are, again, you need to be careful about medication overuse, but there's no miracle in this combination. Those are the commonly available, and basically a cup of coffee with the Tylenol and you get Excedrin right there. That being said, if you take more than 10 pills a month, then you're at risk for rebound headaches. That's the issue. And that's why, as a migraine specialist and headache specialist, I'm not particularly concerned, but I understand that it is very, it's over-the-counter medication, it's readily available. And for some people, non-steroidal anti-inflammatory medications are as effective as the combination. But again, it's a caffeine in this combination that I would be very cautious about. And it's people with a migraine have very complex relationship with caffeine. It's a little bit, can be very helpful, but it's very, very easy to get over the board when caffeine might actually become a problem, because it does have a very profound physiological effect on your body.
Right. Thank you for that. We have another great question. Can your high blood pressure contribute to a migraine?
This was very, very well studied, and many people come to assumptions that because we use blood pressure medicine for migraine prevention, there has to be connection. That most of the time we see people with migraine and elevated blood pressure. When I see it in my office all the time, when person come during the migraine attack, and blood pressure is usually elevated somewhere in the middle to high, usually not the numbers that will require emergency room visit. So it is much more common to have elevation of the blood pressure as a result of the pain rather than a cause. That being said, there are conditions associated with a very high elevated blood pressure that causing a headache, and that can be life-threatening, like subarachnoidal bleed or spasms of vessels as a result of some external substances. So there is important distinction. But the reason why I'm saying that I see more commonly that the blood pressure elevated as a result of the headache, but not a cause of this, is that we do see people that do not have a headache and you get the blood pressure measured, they have extremely high numbers. They don't feel it because they don't have a migraine. So it can go both ways, but if the person has elevated blood pressure and hypertension, which is usually disorder with transient families and has some other underlying causes, that can be used to our advantage. That can help with the choice of medication. Use some of the medications that can be helpful for treatment of high blood pressure and migraine as well. But usually the connection is not that straightforward. So most commonly, it's not. It's a different relationship.
Okay. We have a question about triggers. Someone said that they had like a sound trauma situation where a loud noise caused pain in their ear. And within 15 minutes, they started experiencing an aura that lasted about 30 minutes, develop a severe headache for about 12 hours. And then it went to kind of a duller headache. Does this sound trauma situation sound like a legitimate trigger for that migraine episode?
Well, as I mentioned, loud noise and the sound and light sensitivity more commonly is very commonly reported by people who have a migraine as potential trigger. That's very controversial. So we still don't know how exactly certain particular triggers can actually trigger migraine, this cascade of abnormal activity in the brain. But there's no doubt that some people, this triggers event is so profound that if you have a migraine and you just walk into a perfume store and it starts right there. There has to be something triggering. There's no doubt about that. Just the fact that we don't fully understand what receptors, what mechanisms, does not mean that they don't exist. And again, going back to the legitimacy of this, well, it is a brain disease and it's legitimate as asthma or diabetes. I don't know about the other signs of sound trauma in this particular scenario, because I can't tell this without more specifics for patient, but we only beginning to understand what the mechanisms are actually triggering the migraine attack, where it starts, and there's still yet many things to be discovered.
Okay. The sound that they mentioned was a loud sound at an ATM, like a beep or something like that. So we got a lot of questions about triggers. Someone says, what advice do you have for people who can't really identify what triggers their migraines? Any advice for that?
Well, chasing the migraine may be not very productive, because if you can't identify the triggers, well, then maybe there's a different mechanism, and maybe there are some triggers that you can't manage. And what are you going to do about weather changes? Not much, perhaps, other than okay, if you're very sensitive to heat, well, try to limit your activities to early morning or later in the evening. But it's not always practical. So my advice would be, well, look deeper and make sure that lifestyle modifications, such a common thing, that have regular hours to sleep, hydration, and if the headache is frequent, we'll talk to your doctor about preventive therapies. And make sure that you have good migraine-specific treatment for individual attacks. Make sure that you're not overusing the medications that are not actually changing the course of your disease. And look for medications that actually can change it and reduce your sensitivity to whatever triggers you might have. But again, triggers might be, this is one of the controversy of the triggers. Some people can find the trigger and easy enough to avoid, but for majority, it's not. And I see it all the time. So we use preventive medication and acute medication and just keep looking.
That's a good point. Some things you're never going to be able to avoid. So we got several different questions about medications, and although I know we can't give specific advice, I think some of them are broad enough that we should be able to talk about it. Someone asked about and I'm probably going to say it wrong. Do dietins differ from tryptophans?
Yes. I showed you the little slide about this, when just triptans and ditans work. So there's a number of serotonin receptors in a body. It's a very, very large group, and they have different function, they have different names, distributed in different tissues. So the ones that are important for migraine were 1B, 1D, and 1F. And that is where triptans works. Ditans, or lasmiditan, is so far the only one available medication, works only through 1F. So that's the difference. It's more specific more selective. And those receptors are located in the back of the brain and not in the vessels. So what's the difference here? Now, the practical implication here is that if the person has contraindications to use of triptans, let's say person who had a heart attack, have coronary artery disease or severe peripheral vascular disease, unfortunately, triptans are contraindicated because some of these receptors, 1B specifically, is located on the vessel, so it may worsen the vascular symptoms. When we use medications that do not have this effect on the vessel and still helps with a migraine, that would be lasmiditan. So that would be a good option for person who cannot use triptan, but still can use D-tan, just a newer, more specific, more selective medication.
Okay. Let's see. Could you share some information about the relatively new monthly injectables and how they work?
So those are CGRP blocking monoclonal antibodies. And again, I showed you this migraine funnel, migraine cascade twice today, and you may see CGRP were on the very bottom. So those are the substances directly responsible for triggering the head pain. So injectable medication, monoclonal antibody, they're designed in a way to stay in your body for a long time. And that's why they block CGRP by the receptor or the protein itself, depending on what medication we're talking about. And because they basically wiping CGRP out of your body, that is how they work as a preventatives. So once a month injection, some of them can be used as 3 shots every 3 months, so basically combine. It would be Ajovy, Emgality, and Aimovig used once a month, and the fourth one, Vyepti, is infusion medication, but they all belong to the same class of drug. They block CGRP protein that is proven to be triggering migraine attacks and directly responsible for the head pain. They do work on the periphery outside of the brain. They're too big to cross the blood-brain barrier. That's another advantage of them, because they do not affect the mood, do not affect cognition. And they have a minimal interaction with other medications because they're not eliminated through the kidney or through the liver. There's a different way of elimination, so minimal interactions. So for many people, that might be convenient. The problem is, again, as any preventive medication, there's no 100% proof that no medication is as good that it for every person on earth it would be effective. We don't have that type of therapy yet, so they may not work, but when they work, many people feel that it was life-changing.
Yeah. Okay. Someone asked a great question, I think. Could you help identify what the difference between like severe chronic migraine or a stroke? How would someone know the difference?
So stroke is acute neurological deficit that's caused by lack of oxygen, lack of blood flow to certain parts of the brain. And it does cause irreversible damage to the brain. So it does come with acute neurological symptoms such as droopy face, abnormal speech, weakness on one side. Those are the classic, the most common symptoms. In migraine attack, the transient neurological symptoms usually is, we talk about the aura that lasts 5 minutes to 1 hour. And usually symptoms are, there's a number of symptoms. So it's not a sudden weakness on one side and sudden loss of speech that is typical for migraine attack. It's usually this vision symptoms that starts in one area and they spread and they move around the visual fields and then go away. So that's one difference. But in rare types of auras, such as weakness on one side, that might be diagnostic difficulties. And the only way that I would suggest things that if this is a condition that always come with a headache, and this condition that you have recurrent attacks and they're pretty much the same, and you already had evaluation in emergency room, we discussed with your doctors these symptoms, they're stereotypical, then that's most likely would be the migraine. But remember, again, the migraine comes with other symptoms. And it does go through different stages. Stroke is acute onset, peak of the symptoms from the very beginning.
Okay. We have two questions that are related. So if someone says, if migraines are neurological, why do I get GI symptoms? And one person said that they experience constipation. Another person said they experience nausea.
Mm-hmm. Well, if you go back to our definition from one of the neurological books, that migraine come with very commonly associated symptoms like nausea and vomiting, and the generator of those symptoms is not the stomach itself, but it's come from a posterior part of the brain. That's why the medications that we use to treat nausea don't work on the stomach. It's not an acid reflux. It's a brain condition, and the autonomic nervous system is a part of a nervous system, and the autonomic dysfunction is a common. And constipation can be a sign of autonomic dysfunction during the aura. So there's a lot of different parts of the brain responsible. So let's say the constipation from a migraine has different mechanism from constipation from dehydration and a lack of fiber in your food, in your diet. But it may still work, kind of having balanced diet with the fiber, it may still help improve your quality of life, but mechanism is different.
Okay. Someone asks about tenderness on the scalp around the base of the skull during headaches or migraines. When they press down, it can be very painful or radiate to other areas. Can you discuss what happens and what they can do for that, maybe?
This is a very interesting phenomenon, and for the most part, we even have a fancy term for this called allodynia. What it is that the sensitivity of the brain that's triggering the sensitivity to certain part of the skin. It's not necessarily in the head. Some people feel that just touching the skull hurt, brushing hurt, but it can happen everywhere in the body, and it can happen in the arm, it can happen in the leg, in the body, and that's why people during migraine attacks, not the people that would like to have kind of rubbing their neck or having massage, that can hurt. And it's, but what it means is that as a migraine travels through different parts of the brain, it goes to the deep structure in the brain called thalamus, and thalamus is the hub for all our sensory stimuli. And when it gets to that level, it means that it's deep enough. This is long enough attack, and that may actually be a sign of undertreated migraine, or that you may not have good enough or working fast enough medication. So it is one of the symptoms of a migraine called allodynia most of the time. What to do is that, well, what do recommend to treat migraine, as I said earlier, more aggressively, and sometimes additional stronger anti-inflammatory medication may help with this condition. But think about it as a migraine part of the migraine phenomena, and we're going back to prevention and treatment of individual attacks rather than managing symptoms one by one.
Okay. Someone asked a question. I take Topamax for the prevention of migraines, but I also take NSAIDs for rheumatoid arthritis. And now I've been experiencing chronic headaches. Could these be rebound headaches?
That's a good question. It is possible, but the bigger question, what to do about it, right? That's a bigger question. If someone need to take this medication for other condition, well, he thinks that the solution would be to use for migraine specifically migraine-specific medications. Let's say instead of ibuprofen or naproxen or whatever non-steroidal anti-inflammatory medication individual already taking, On the days with migraine attack, use migraine-specific drug. And again, optimization of preventive therapies. If something is not working, if a headache getting worse despite of taking medication, it might be either dosage is not enough, or maybe different medication need to be tried, or there's some other factors. But the problem of rebound headaches or medication overuse headache is that just simply telling the person that, well, this comes from overuse of medication, stop doing this, not always practical, not always working. So we have to find other solution. And again, preventive medications probably would be a better solution in this case.
Okay. So someone asked a question. I'm currently taking tryptophan 1D/B with mild cardiovascular side effects, but it's effective at stopping my migraine. Do you think I should talk with my doctor about trying out Ditan 1F as an alternative?
Yes, but at the same time, it is important to realize what kind of cardiovascular effect and what does it mean, a cardiovascular effect, right? Because many people with triptans, because with using triptans, well, example, sumatriptan, rizatriptan, so there's a number of those. They may experience so-called triptan sensation when some people may have a tightness in the chest or tightness in the muscles in the throat. Some people may have a muscle pain, but it does not mean that the person is experiencing a heart attack. It's a different story when the person has non-coronary artery disease. And then triptans are contraindicated. So not all symptoms from a triptan indicate that there is a cardiovascular disorder is going on. There's a different mechanisms, and trying different triptans that are slower or such a, let's say, a longer acting triptan or narrotriptan, or try different triptans that are newer, may actually have less side effects. So there are two questions here. One, is it true cardiovascular risk factors? And yes, definitely I would consider changing. Or if there is a side effects not necessarily causing cardiovascular complication, as sensation of a tightness not necessarily means that there's a heart attack is ongoing, then trying different triptan may be also other option.
Okay. So I got two questions about like onset of the age when they started getting migraines. One says, is it common for a 30-year-old to start getting them? And then someone says, I'm 74-year-old male and I started getting them. Is that kind of a common occurrence that they can occur at this wide variety of times?
So it's not that common. What is much more common is that when we experience something as a children or a young adult, and then headaches going away and then it come back, it's very common, don't make even a connection. So it's very commonly, I hear from patients that I have a headaches that started, say, a few years ago, and then we ask a specific question and go back, and they say, yeah, I had the headache around the periods. Yeah, of course, I had a headache when I was hungry. Of course, I had a headache. Who doesn't? Well, many people don't, but they may not even have a connection because the symptom has changed over time. So that's one thing. But in a 30-year-old, yes, you're still in that group that it's common. Not everybody has a headache since they were a teenager. So this is still typical timing. But if first ever headache started in your life and you never experienced a headache and there was no headache in the past and you're in the 70s, you need to talk to the doctor, because this is more atypical than the same scenario in somebody who is 30 years old. Again, it might be still recrudescence of prior disorders that you may even long forgotten or never made any connection, because what connection can it be what was happening in 20s and now in 70s? There might be still a connection, but we generally, as our general rule of thumb, if there's a true new onset of headache in an individual after 50s, we keep looking for alternative diagnosis. And if there's no other alternative, yes, it's still possible, but they need a thorough workup and discussion with the doctor.
Okay. Someone also said, my doctor's prescribed anti-nausea medicines, Reglessin, and then Valium, but vomiting seems to set in before the drugs are effective. Any suggestions for that?
So I recommend my patients who have a vomiting as a part of the migraine attack using suppository or melting pill, or try nausea medicine earlier when the nausea is still very mild. But if the person is vomiting, yes, there is no pill, so you will not be able to hold the pill. So suppository is a one way to administer nausea medication, and there's a number of suppositories that are very effective and work as fast as intravenous. It's not the most convenient way to administer medication, of course, but yeah, this is a good alternative. Injectables, which is less convenient, and again, treat it early. Don't miss this opportunity to treat the migraine when it's just even a minor nausea. It may be more effective. But if you're vomiting, then other way to get the medications, injector and suppository, is still available.
All right. Can you talk about what is a vestibular migraine?
So vestibular migraine is an entity that is getting a little bit of controversy because people with a migraine prone to vertigo, but there's different types of a vertigo. And the vertigo as a symptom is very, very common, and it can come from an inner ear, can come from a brain stain, from a brain condition. And basically, when we talk about vertigo, it's sensation of a spinning, it's a sensation of the motion, which is not the same as dizziness. So I want to make this distinction clear. So the migraine attack can come with vertigo as associated symptoms when a person has all the other symptoms of the migraine. But in less commonly, this vertigo can be the only sign of the migraine. But the way how we think about vestibular migraine these days is that there has to be some other symptoms of a migraine. For example, sensitivity to light, sensitivity to noise. Well, nausea is very common with vertigo, whether this is coming with a migraine or not. So we can't rely on these symptoms. When you feel vertiginous, you usually feel sick to your stomach. But if there's sensitivity to light, and pay attention to the headache, and its duration is 4 to 72 hours, just like a migraine attack. That can be true vestibular migraine. And I had some of the patients that tried treating it as an individual, the same way as a migraine attack, and it did help. But it's not always, because as I said, there's different types of vertigo, and there's different causes of that. So we're studying it now and hoping to get more understanding of this condition.
So I think I'll take our last question here. It says, I don't see on your list of medication beta blockers. Are they a possible treatment? And are they the same in the category of B androgenic, that category you listed?
Yes, that is a beta blockers. So beta blockers is a short for beta adrenergic receptors blockers. Yes, that's the same class. Correct.
Okay. All right. Well, I thank you so much for the time that you took to give this today. You obviously are very knowledgeable about a topic that I didn't realize was nearly as prevalent as it is. So I know this is going to be great information for all the people out there. So thank you so much for speaking today.
Well, thank you for having me.
Yeah. All right. Thank you.